Today we are going to discuss about hemiplegia. Hemiplegia means weakness on one side of the body. Weakness can be complete when we prefer to use the term hemiplegia, whereas if it is incomplete, hemiparesis will be more optimal. Both are used synonymously. When we think of hemiplegia, weakness on one side of the body, the etiology can be anything. The commonest or the term that comes immediately into our mind is cerebrovascular accident. But you should also understand that there are many other reasons with which a patient can develop weakness on one side of the body. It can be a compression from outside the vessel as in a tumor, or it can be a direct damage to the nerve cells or the axons as in case of degenerative disease or demyelination disorders or other inflammatory conditions due to infections, encephalitis. So all these can lead to weakness. When we think of cerebrovascular accident, first of all we should think about the risk factors for stroke. The risk factors for stroke includes the classical systemic hypertension, type 2 diabetes mellitus, dyslipidemia, then cigarette smoking, and also rhythm disturbances of the heart, especially atrial fibrillation, and other structural disorders of the heart which can lead to an embolus formation within the heart, which can go into the systemic circulation, especially cerebrovascular vessels. Then physical inactivity is also a risk factor. Obesity, stress, etc. should be considered when you think about the risk factors in cerebrovascular accident. Obstructive sleep apnea, family history, age, etc. are also very important. Then males has got more risk than females in develop a cerebrovascular accident. What are the symptoms and signs of cerebrovascular accidents? Symptoms and signs depends upon the vessel that is affected or the area of the brain that is affected. Commonest is weakness on one side of the body. It also can be due to loss of balance, or it can be sensory disturbances. Again, if the posterior part of the brain is affected, equilibrium disturbances, that is ataxia, can be the main presenting feature. Or if the coordination of the eyes, that is the brainstem, especially the midbrain is affected, coordination of the eye movements will be affected. So the presentation depends on the area affected. If lower cranial nerves are affected, patients can develop swallowing disturbances or dysarthria. And cognitive impairment is mainly a feature of frontal lobe involvement. And changes in the conscious level and developing into coma can be a feature that is seen in massive hemispheric involvement, or even the ascending reticular activity system involvement as you see in brainstem stroke. What are the types of hemiplegia that we see? When you think of a hemiplegia, usually the student will ask, or the teacher can ask to the student, is it cortical or subcortical? If it is subcortical, is it in the corona radiata or in the internal capsule? Then comes the brainstem. So these are the areas where a brain stroke, means if it is inside the skull, it can develop hemiplegia. So if it is cortical, it is usually non-dense, and speech affect, mainly speech will be affected, and also apraxia or cortical sensory disturbances, etc. are also very important when you consider the stroke as cortical. Then if it is subcortical, especially corona radiata, it is non-dense and you won't get any cortical signs. In the internal capsule, you will get a dense hemiplegia and also without cortical signs. So dense hemiplegia with UM facial palsy is the classical presentation in internal capsular stroke. It is usually motor, but associated sensory or other signs depending on the site of involvement. Then brainstem stroke or hemiplegia is usually crossed, that means ipsilateral cranial involvement and contralateral weakness. Ipsilateral means the cranial nerve will be on the same side of the brainstem that is affected, whereas weakness will be on the opposite side. Classically is Weber syndrome, where ipsilateral third cranial nerve is involved with the contralateral hemiplegia. Let us think about the clinical features. Then ischemic stroke clinical feature depends upon the onset and progression. If it is embolic stroke, onset will be sudden and progression will be complete within minimal time. That is the embolic stroke. Whereas if it is thrombosis, usually patient presents with morning weakness. That means when they get up from the bed, they found they are unable to get up because of weakness on one side of the body. This is a classical picture of a thrombotic stroke. Whereas if the patient has got hemorrhage, the presentation will be headache, vomiting, seizure, and discontinuing antihypertensive therapy. So this is a picture that we see in hypertension patients with hemorrhage and hemorrhagic stroke. So the symptoms or signs depends upon the type of the stroke and the site of involvement. What is the pathogenesis? Pathogenesis depends upon how much blood is prevented to go into an area of brain. If it is complete cessation of blood flow, infarction is the result. But if it is 16 to 18 ml per 100 gram tissue, infarction within an hour can occur. If it is 20 or 24, there is only ischemia without infarction. That means you can salvage, you can save the area. Blood flow is restored with treatment or without treatment within 24 hours. The picture will completely disappear and we call transient ischemic attack, TIA. And when it affects the retinal vessels, TIA affecting the eyes, we call it as amaurosis fugax. Then, so the goal of treatment in ischemic stroke is saving the area surrounding the infarct. We call it as ischemic penumbra. So the zone of infarct will be surrounded by an area of ischemia which can be saved with appropriate treatment. This is the intention behind starting treatment, either thrombolytic or anti-ischemic. Two important things that are important for functioning of the neurons is oxygen and glucose. So with our treatment, this will be established. Without treatment, this will be depleted. So depletion of oxygen and glucose will lead to development of various symptoms and destruction of the neurons. So the decrease in the glucose will lead to malfunctioning of the mitochondria. This will lead to membrane ion dysfunction and influx of calcium into the neurons. So the intracellular calcium increases and leading to glutamate release, and this can lead to damage to the neurons. So the subsequent release of free radicals into the neurons lead to complete damage. See, this clinical picture shows the types of stroke. One is hemorrhagic, the other is embolic. You can see the embolus within the vasculature, the other is the rupture of the vessel and escape of blood into the tissues. Then, the clinical picture in acute lesion. Most of the patients come to the ward with stroke, but the features will be element type. That means weakness will be flaccid complete, reflexes will be absent, tone will be hypotonia. This is classically mentioned as element pattern, but this occurs when there is a neuronal shock which can last up to 2 to 6 weeks. So human lesion can present as element pattern when the patient is neuronal shock. But if the obstruction is gradual, as in the case of compressive lesion, or if as in the case of demyelination or degeneration, the presentation will be typical of pyramidal type. That means weakness, hyperreflexia, hypertonia, upgoing plantar, absent superficial reflexes. So the features, once again, see the features: paralysis, hypertonia, hyperreflexia, absent superreflexes, classical upgoing plantar, and the gait will be hemiplegic. Again, localization already we have told. Once again, we will come to localization. See, If it is cortical, what are the features we will see? There can be involvement of the speech, there can be apraxia, that means unable to perform a non-motor activity. Then convulsions can occur and you will see opposite side weakness. In massive cerebral infarct, you can even see impairment of conscious level. Internal capsule. Internal capsular lesion, dense hemiplegia with human facial palsy. There can be hemiparesis, no seizure, no aphasia. That means cortical signs won't be there. Hemianopia can be associated. Brainstem lesions classically present, I told you, on side, same side, cranial nerve, opposite side, long tract signs, which can be sensory or motor. In Weber's, it is the weakness, whereas in lateral medullary syndrome, it presents with the spinothalamic, opposite side, spinothalamic. Face, same side, fifth cranial sensory involved. So, same side, facial sensory loss will be there, but opposite side, body sensation will be lost. And again, in brainstem, multiple long tracts can be affected, not only sensory but also motor. Okay. This slide we can see the internuclear ophthalmoplegia. This is an important pinpointing sign of involvement of the midbrain and medulla. See the midbrain especially. Here the coordination of activity between the fourth and the sixth via the MLF through the PPRF and even control from the frontal lobe. So this picture shows the one side third cranial and opposite side sixth means works together so that horizontal eye movement will be together. If it is affected, one eye may not move to one side. So abduction of one eye won't be happening if there is involvement of the MLF. This focuses the lesion to brainstem, midbrain. Investigations can be just like sugar, average blood sugar, blood count, RFT, LFT, etc., etc. And the importance should be given to ECG because arrhythmias and infarctions can be detected from ECG, which can lead to embolic stroke. CT to rule out hemorrhage first. So first you take a CT, rule out hemorrhage stroke, then you will send for other investigations or treatment, because if it is hemorrhage stroke, the management will be entirely different from that of ischemic stroke. See MRI ischemic stroke picture. You can see the lesion in an MRI stroke. See CT, hyperdense lesion in the CT in a hemorrhagic stroke. The other investigations specific to the vessel can include Doppler study, which will help us to see the block. Both systems can be tested, anterior and posterior circulation. Then CT angiography, MR angiography, digital DSA. DSA is a very important, especially to see the vasculature intact, and also cerebral angiography when you are planning to do a procedure. Management, general management is there. Here we will think of the ABC, airway, breathing, circulation, and from there you also think of the skin care, and you will think about the throat, common passage for air and food, that if there is any problem in that area you should clear, preconstruction especially in lower cranial involvement. Then you have to consider oxygen, fluid and electrolyte management. Then nutrition, very important, especially high protein diet. Then DVT prevention. The specific management is, one, if there is hypertension, manage, but in ischemic stroke, very slowly only you should bring down the blood pressure. But if it crosses more than 220 to 120 or 110, you can consider starting a antihypertensive after a period, because within that period autoregulation may control the blood pressure. If it is not happening, then a very small dose of antihypertensive like labetalol bring down up to 25% reduction, not more than that, because if you bring down the blood pressure drastically or suddenly, the ischemic penumbra may be involved and there can be loss of that area. Then if it is a hemorrhagic stroke, you should immediately bring down the systolic blood pressure to 130 or around 130. Otherwise, further bleeding will complicate the picture. Then hyperglycemia should be managed with insulin. Keep it around 140, but never hypoglycemia. Anti-ischemic treatment is mainly IV, recombinant tissue plasminogen activator, RTPA. So this can be started within the window period, up to 4 or 4.5 hours. Then aspirin 325, statins, then other anti-diabetic, anti-hypertensive medication as mentioned. Then also you can consider therapeutic hypothermia. In selected case of massive hemispherical infarct, you can consider craniotomy. Then thrombolytic therapy usually will start with IV RTPA, 0 to 4.5 hours. Systemic thrombolysis, the dose is 0.9 milligram per kilogram, not to exceed 90 milligram. And 10% of the dose will be given over 1 minute and the rest as infusion over 60 minutes. Another agent is tenecteplase. It's a genetically engineered tissue plasminogen activator, longer half-life and very specific. This also can be considered. Efficacy is almost same as RTPA. Antiplatelet should be started as early and continued as secondary prophylaxis. Then clopidogrel aspirin combination is very effective when there is TIA for a period alone. Then aspirin can be continued. Ticagrelor is also recently promising drug. Statins, atorvastatin and rosuvastatin can be considered 20 to 40 milligram per day, and you can follow up till the cholesterol is controlled. And when there is elevation of triglyceride alone, you can consider fibrates. Neuroprotective agents not clearly mentioned as effective, but still consider magnesium sulfate, albumin, lovastatin and high dose vitamins. What are the conditions that mimic stroke? You can get stroke-like picture in hypoglycemia, seizures, migraine with aura, Wernicke's encephalopathy, hypertensive encephalopathy, CNS tumors or abscesses, drug toxicity and psychogenic. So all these you should keep in mind when you see a patient with a stroke, because these can also mimic a stroke. See, what is the complication of a large infarct? You can see a herniation in MCK infarct with pushing the center to the opposite side. So this can be prevented by removal of a bone piece from here. That is this picture. Second picture shows a bone piece is removed. The edematous tissue goes out into the scalp, not pressing the opposite brain and compromising the function of the brain. Other interventions which you can contain the clot and bring it out with stent. See, beautifully the clot is trapped within the stent. And if it is an aneurysm that is going to rupture or producing symptoms, you can put a coil inside that coil, and using a stent you can block it. These are the various methods: thrombolysis, aspiration, wire manipulation, stent retriever and MERCY. Other important supportive measures include physiotherapy, speech therapy, psychotherapy, swallow therapy and occupational therapy. Physiotherapy is very, very important, with which only we can bring back the patient's muscle power. So when the brain repairs by itself, we can keep the body intact so that the patient will be able to walk. Speech therapy when there is involvement of the lower cranial nerves or in speech involvement, aphasias. Then swallow therapy to prevent aspiration. That also is very, very important and promising. Occupational therapy will help the patient to come back. That is coming as part of rehabilitation. So today we have discussed the localization of hemiplegia and the treatment of hemiplegia, and finally how to rehabilitate the patient. Thank you.